Hi everyone, it's Derek here from Mrcgp. Migraines are a really common condition. In today's video, I'd like to take a look at what you actually need to know about this topic. Migraines tend to present as unilateral and last between 4 to 72 hours. Now, our patients typically describe a throbbing or pulsing type sensation and may have associated symptoms such as photophobia, phonophobia, nausea, and vomiting. Prior to a migraine starting or together at the beginning of a headache, our patients may experience an aura which may either be visual or sensory. Migraines are commonly triggered by stress, sleep disturbance, and certain lifestyle choices such as excess caffeine, chocolate, and a lack of exercise. Migraines are up to 3 times more common in women. A typical migraine aura starts gradually over at least 5 minutes and can last between 5 minutes and an hour. It can either be accompanied by the headache or the headache may start within 60 minutes of the aura. Some examples of a visual aura includes the presence of zigzag lines or the presence of scotoma. So when we assess our patients with migraines, it's important that we're aware of and that we're able to rule out our red flag symptoms. So this will include ruling out any infectious symptoms such as temperature, neck stiffness, or reduced GCS, and also thinking about symptoms of a space occupying lesion, which may include headaches that are worsened on position or on the Valsalva maneuver, and of course patients that have new neurological symptoms. So when we think about the management of this condition, we've got a few options. Let's start off by looking at the conservative options. This will include giving the patient an information leaflet, discussing the use of a headache diary to aid identification of triggers, and also lifestyle modification such as ensuring adequate sleep and getting in some regular exercise. We need to ensure that any females that have a migraine with aura are not on the combined oral contraceptive pill. We also need to think about differentials such as medication overuse headache, which is really common in patients that present with migraines. So let's take a look at our medication, starting with our acute treatment. Starting off with our simple analgesia such as paracetamol and ibuprofen, which patients may find helpful. Also think about our triptans, which can be used either alone or in combination with paracetamol or a non-steroidal anti-inflammatory drug. Our medication should be taken at the start of the headache and not the aura. Oral sumatriptan is the first line and is usually given at a dose of 50 to 100 milligrams. Antiemetic can also be considered. Let's take a look at prevention because the main aim here is to reduce the frequency, the severity, and the duration of attacks. So we can think about prevention if migraines are affecting a patient's quality of life and their daily function. Our treatment options for prevention of migraines includes propranolol, amitriptyline, and topiramate. With topiramate, we need to be aware that this medication is contraindicated in pregnancy. Patients will also need to be on highly effective contraception prior to commencing topiramate because it may reduce the effectiveness of contraception. Our medications can be up-titrated as needed with the help of a headache diary. It may take up to 4 to 8 weeks from the medication being started to see any improvement. We should refer onwards to neurology if our prophylactic treatment fails. Now, treatment failure is defined by NICE guidance as no response to the highest tolerated dose after 3 months of treatment. We can consider alternatives to medications. This could include mindfulness, CBT, and relaxation methods. Thanks a lot for watching today's video. As always, if you found it helpful, don't forget to leave a like and subscribe. I've also attached a link to another video that I think you found really helpful, so make sure you check that out too. Until the next time, I'll see you soon.